Hi guys, in this video we're going to have a look at the management of patients with a chest tube in situ. We'll have a look at some of the physiology associated with chest tubes and some of the troubleshooting and just general care and maintenance that you might need to perform while you're transporting these patients either between hospitals or from an air ambulance. To quickly review our physiology, we know that the lungs reside within the pleura, which is folded back on itself to form a double layer sheath. It's nominally divided into two sections, the green being the visceral pleura, which surrounds the lung, and the blue is the parietal pleura, which coats the inside of the rib cage. In the cavity between those two layers of pleura is some serous fluid, which performs two functions. The first is to allow the lungs to slide around within the thoracic cavity with no friction. The second is to allow for a degree of surface tension to exist between the two layers of the pleura, so that when someone uses their muscles of breathing to expand their rib cage, that expanding rib cage generates a negative pressure through that intrapleural space, which drags the lung out and expands the lung through a force of essentially suction. Where we start to have an issue is when we acquire an accumulation of either blood or fluid within that pleural space, which would serve to break the surface tension and allow the lung tissue to recoil. This can occur due to the rupturing of a bleb within the lung itself, so air will actually flow from the lung into the pleural space, or as a result of penetrating trauma from the outside, so for example a stabbing, where air is allowed to enter from the atmosphere into that pleural cavity. This accumulation of blood or air within the pleural space can result in compression of the lung on that side. So we need to drain the contents of that pleural space, and the pre-hospital environment we do that either by needle thoracostomy or open thoracostomy. This only provides really a temporary measure, with the definitive treatment being the insertion of a tube with a seal that prevents any air coming back into the chest. So to create this seal, we take the open end of the patient's chest tube and place it underwater in a vessel. This performs two functions. The first is to allow air or fluid to escape from the pleural space without allowing air to flow back in. The second is that by breathing against the water in the chamber, it allows the patient to generate their own negative intrapleural pressure during inspiration, and that helps to restore some of the normal kinetics of ventilation. Now this works fine in the setting of a pneumothorax, where all that's coming out of the patient's pleural cavity is air. In the setting of a hemothorax, as the blood tends to collect in the underwater seal vessel, as it fills, there's going to be an increasing positive pressure generated back up through the chest tube into the patient, and eventually as that fills up, it'll either overflow, or B, it'll cause an occlusion of the chest drain, and essentially we'll have a closed pneumo or hemothorax once again. So to combat that, we'll have a second bottle, which is a collection chamber, here as much as the trap bottle. So the chest tube will flow into the trap bottle, which is empty. All the fluid will collect in the bottom of the trap bottle, while the air is transmitted through a tube to the underwater seal bottle. To evacuate the pleural cavity of blood or air, you might require suction. So commercial units include a third chamber to closely regulate the degree of suction pressure. This chamber is filled with water, the height of which is equal to the negative pressure generated during suction in literal centimetres of water. And a ventilation tube acts as a relief for when there's excessive suction applied from the outside source. So it's therefore the water in the chamber rather than the external suction that determines the actual suction pressure at the patient end. This same 3-bottle system is conveniently packaged into a single unit, such as the atrium one we see here. So when we receive a patient with a chest tube in one of these underwater seal units, there's a few points that we have to remember when we're handling the unit itself. Firstly, we need to keep the unit below the level of the patient, and that's because if we lift it up the forces of gravity may prevent anything draining for a start from the chest, but also may allow some of the fluid within the system to flow back in towards the patient. For the same reason, we don't tip the unit over, because that will allow our fluids within our unit to spill into other chambers, and may allow some of that non-sterile water to flow back into the patient's chest. We also need to be mindful of the position of our tubes. We don't want to clamp or compress those tubes in any way for any period. If we do that, essentially we create a closed pneumo or hemothorax again that could potentially retension. For the same reason, we also don't connect the suction if we're not going to use it. So if the suction is not being prescribed and it's not actively sucking, then we leave that port free so it can vent to the air. We need to also note the level of fluid that's already drained from the patient's chest when we first receive them. That way we can track the amount of output that's coming during our transport. If there's a sudden increase in blood or fluid coming out of the chest and collecting in our seal, for example, we'll know that something has happened within that chest cavity. Perhaps there's a sudden increasing hemothorax. While we're monitoring the collection bottle for blood, we also need to monitor the underwater seal bottle for air. This will present as bubbling. If we are expecting that there will be some drainage of air from the pleural cavity, we will see some bubbling during our transport. However, if we have a sudden increase of rapid bubbling, we may have developed an air leak in the system at some point between the patient and the bottle, and we'd need to work through and find out where that exactly is. And to do that, we would progressively clamp the tube temporarily, first at the patient, and then progressively distally towards the unit, monitoring for a cessation of bubbling at each point, and that will allow us to narrow in to the point at which the air leak that we suspect there is actually present, and then we can address that with either tape or fixing a connection or something like that. If we are using suction, we will expect to see some bubbling through that suction bottle as air is pulled through the vent tube, so that's not something that we need to worry about. We're just mostly concerned about bubbling within the underwater seal bottle. Another issue that we might face as we transport our patient with this unit attached is either the unit fails, it breaks, or we drop it or tip it over. And in that case, we may need to do something to actually reseal that tube again. One thing that we can do is actually unplug the tube from the unit and place the tube in simply a bottle of sterile water, which will provide that underwater seal as a temporising measure until we get to a new unit or to the hospital. Another potential issue is a clot or a blockage in the chest tube itself. If you can identify it, you could potentially change the tube, but if the blockage is within the tube within the patient's chest cavity, you may not be able to fix that, in which case if the patient begins to retension, you might get to the position where you have to either decompress with a needle thoracostomy or simply pull the tube from the patient so that you have an open thoracostomy. If you were to do that, you'd need to then seal the chest with a 3-sided occlusive dressing. And obviously our patient has a chest tube for a reason. Now, they've had some either chest surgery, a chest injury, or some other pathology within the chest there that's caused them to require this chest tube. So we need to continue to monitor our patient for clinical signs of tension physiology and intervene if we need to.